Good afternoon. Also, continuing with the topic, the drugs, hormones that are used in calcium disorders and bone diseases, or the drugs or the hormones that takes part in the calcium homeostasis. So we did with the hormones that takes part in the calcium homeostasis. So including the parathyroid hormone, vitamin D, and calcitonin. So these are the endogenous hormones that is secreted by the body that takes part in the calcium homeostasis, and synthetic analog of these hormones are also present. And continuing with the same, so we are going to discuss about the drugs, so which are non-hormonal agents or the drugs that affects the calcium homeostasis. So in which the bisphosphonates is the main drug. Bisphosphonate is why it's important because sorry, Krishna. एकैछिन है म फेरि जोइन गर्छु है आई होप अहिले भयो होला So continuing with the same topic, that is the drugs, hormones that takes part in the calcium homeostasis. So parathyroid hormone, vitamin D, and calcitonin are endogenous hormones that takes part in the calcium homeostasis, and synthetic analog of these hormones are also present, which are used in different bone disorders. So, and we are now continuing with the non-hormonal agents that affects the calcium homeostasis. So one of the important drug agent in the non-hormonal agents that affect the calcium homeostasis is the bisphosphonate. So why it's important? Because it is drug of choice for many bone disorders, especially osteoporosis. So may it be age-related osteoporosis, may it be postmenopausal osteoporosis, or may it be idiopathic osteoporosis, or steroid-induced osteoporosis. So bisphosphonates is the drug of choice in many cases of the osteoporosis. And normally, so in hydroxyapatite crystals of bone, there is presence of pyrophosphate in the form of phosphorus, oxygen, phosphorus moiety. So there is presence of phosphorus followed by oxygen and phosphorus moiety in hydroxyapatite crystals of bone. And bisphosphonates are synthetic pyrophosphate derivatives in which the oxygen atom that is present in the pyrophosphate that are present in hydroxyapatite crystals of bone are replaced by the carbon atom. So forming of phosphorus, carbon, phosphorus moiety. So this oxygen atom has been replaced by the carbon atom in bisphosphonates, and this makes the structure of the pyrophosphate that are completely resistant to hydrolysis, as well as they are chemically extremely stable. And the major mechanism of action of this bisphosphonate is inhibition of osteoclastic mediated bone resorption. And as said earlier, they are most effective anti-resorptive drug and drug of choice for many cases of osteoporosis, and can be grouped into three generations. So first generation being the firstly introduced, firstly discovered bisphosphonates, so consisting of the etidronate, liodronate. Second generation becoming the drug remain here, the palmidronate and alendronate. And the third generation bisphosphonates, which are recently discovered drugs, and these are the most potent bisphosphonates, so consisting of the residronate and zolendronate. So यो जेनेरेसन्सहरू चाहिँ नि याद हुनुपर्छ है. And mechanism action of this bisphosphonates, it's not fully understood, and the structural resemblance of these bisphosphonates with pyrophosphate that is present in the hydroxyapatite crystals of bones give these drugs a high affinity for bone, and they probably remain in bone for many years. So coming to the mechanism of action, although it is not well understood, so it has been thought that bisphosphonates gets localized under the surface of the osteoclast due to their high affinity for the calcium ions. So there is a present. So this is the bone matrix consisting of the osteoclast cells and osteoblast cells. And bisphosphonates, they do have very high affinity for the calcium ions that are present in the bone. And bisphosphonates, after they are given, so they gets localized under the surface of the osteoclast, which are the bone reserving cells. And when osteoclasts attach to the bone matrix during the bone resorption process, these bisphosphonates that are present under the surface of the osteoclast are released, which are then internalized by the endocytosis process into the osteoclast to accelerate their apoptosis. So after the bisphosphonates is being given, it gets under the surface of the, it's deposited under the surface of the osteoclast. So this osteoclast are the bone reserving cells. So when bone resorption process is going on by the osteoclast, so these bisphosphonates that are present under the surface of the osteoclast gets internalized by the endocytosis process into the osteoclast and causes the apoptosis of the osteoclast. So it causes the death of the osteoclast, thus decreasing the number of the osteoclast. So number of osteoclast is therefore reduced, and hence the resorption process, bone resorption process gets decreased. And additionally, so apart from its bone reserving process, inhibition of bone reserving process by inhibiting the osteoclast by causing the apoptosis of the osteoclast, so it do have the another mechanism of action as well. So in addition to that, they appear to affect the osteoclast precursor and inhibition, and causes inhibition of their differentiation by suppressing interleukin 6. So for the formation, for the conversion of osteoclast precursor to the mature osteoclast, which causes the bone resorption, there is requirement of the interleukin 6. So this group of drugs, bisphosphonates, what does they do? They inhibit this interleukin 6 and hence inhibit the conversion of precursor of osteoclast to mature osteoclast, and hence causes the inhibition of the bone resorption process. And in addition to that as well, so it has got the another mechanism action. So as for example, so second and third generation bisphosphonates like zoledronate, etc. So they causes the blockade of the mevalonate synthesis. And if you remember, so mevalonate is the rate limiting step in the cholesterol synthesis, and HMG-CoA gets converted into mevalonate with the help of HMG-CoA reductase enzyme, so which is the rate limiting step in the formation of the cholesterol. So this second generation and third generation bisphosphonates, so they block the mevalonate synthesis, and that appear to be critical for osteoclast survival. So mevalonate may be serving as critical factor for the osteoclast survival, and these statins, as for example rosuvastatin, simvastatin, so they block the mevalonate synthesis and may constitute another approach towards management of osteoporosis. So these statins, as for example rosuvastatin, simvastatin, so this group of drugs, they inhibit the mevalonate synthesis, which is the rate limiting step in the cholesterol synthesis, and mevalonate appears to be critical factor for the survival of the osteoclast. So when these statins inhibit the mevalonate synthesis, so osteoclast survival may not be there. So this forms the third hypothesis for the mechanism of action for bisphosphonates. And regarding the dosing of these bisphosphonates, so bisphosphonates are dosed on daily basis, on weekly basis, monthly basis, or some bisphosphonates, as for example, zoledronate, are administered on the yearly basis. So depending on the drug, and some of the bisphosphonates has very long half-life, up to 10 years. So these bisphosphonates are dosed on daily basis or weekly, monthly, or the yearly basis. And the major drawback of these bisphosphonates, especially when bisphosphonates are given as oral route, as oral administration, these oral bisphosphonates are poorly absorbed and produce gastric irritation as major adverse effect, so causing esophagitis as major side effect. and hence they are contraindicated in the patients who are suffering from the gastroesophageal reflux syndrome, peptic ulcer, gastritis, etc. And to prevent this adverse effect associated with zoledronate, these bisphosphonates, that is the esophagitis. So patients who are taking bisphosphonates orally, so they are advised not to take anything by mouth except water, and not to lie down for at least half an hour after consuming the bisphosphonates. So remember, so esophagitis, gastric irritation is the major adverse effect of bisphosphonates, especially if these bisphosphonates are taken as a oral drug or oral route. So uses, it is the first choice of drug in the treatment of osteoporosis. So it can be any form of the osteoporosis, may it be a postmenopausal osteoporosis, the osteoporosis that occurs in the woman after in the menopausal state after stopping of the menstruation, or it is a first choice drug. It is also the first choice drug in age-related or senile osteoporosis. Similarly, it is also the first choice drug in the treatment of steroid-induced osteoporosis. So if you remember, so steroid has major adverse effect of causing osteoporosis. So it is a first choice drug for treatment of the steroid-induced osteoporosis as well. Or if the cause of osteoporosis is not known, so it is also the first choice drug for the treatment of idiopathic osteoporosis. Similarly, they are drug of choice in the treatment of Paget's disease. So Paget's disease ma hamle calcitonin pani pareko थियौं. Calcitonin is used as a treatment in the as a treatment modality in the Paget's disease. So, but when you compare the efficacy of calcitonin and the bisphosphonates, so bisphosphonates rank first. So they are the drug of choice in the treatment of Paget's disease. They are more convenient, more effective, and cheaper than calcitonin. So Paget's disease, which is characterized by the excessive bone resorption followed by the bone deposition as well, but but this gives the bone structurally disorganized structure, so which is weaker as well as less compact and more susceptible to fracture as well. And however, these bisphosphonates have slow onset of action, and calcitonin has a very rapid onset of action. So usually calcitonin is first given and then is followed by the administration of bisphosphonates. So combined with bisphosphonates, so calcitonin combination use of bisphosphonates along with calcitonin increases the efficacy in the treatment of Paget's disease. And this bisphosphonates inhibits the bone resorption process in Paget's disease. So it is used as drug of choice in the treatment of Paget's disease. Similarly, hypercalcemia of malignancy, which occurs in the cancer patients, in which there is a resorption of the bone leading to the increase in the calcium level in the blood. So they are also given in the treatment of hypercalcemia of malignancy. So for the treatment of hypercalcemia of malignancy, calcitonin can be also used, but the better drug is the bisphosphonates. And similarly, osteolytic bone metastasis. So it is the bone metastasis, bone cancer, in which the primary site of cancer is different and it has been metastasized to the other part. So mostly it is the bone, and it leads to the resorption of the bone, so increasing in the serum calcium level. So it is also the drug of choice for osteolytic bone metastasis. So in both the hypercalcemia of malignancy as well as the osteolytic bone metastasis, it inhibits the osteoclastic mediated bone resorption. Etidronate, it is the first bisphosphonates to be used clinically, but however, it also causes interference with the bone mineralization, and continuous therapy with etidronate produces osteomalacia, and its use has been largely replaced in the treatment of osteoporosis. So other drugs or the bisphosphonates are used for the treatment of bone-related disorders. Zoledronate, so it is the third generation bisphosphonates and the most potent bisphosphonates among all the bisphosphonates, and it is usually given once a year. And IV administration of zoledronate is done once a year, and it is the most effective and faster acting drug among the bisphosphonates for the treatment of hypercalcemia. And the major adverse effect of zoledronate, it is associated with renal toxicity, and it may rarely cause osteonecrosis of jaw. Coming to other drugs which takes part in the calcium homeostasis apart from the bisphosphonate, so there is strontium renylate, and it is the group of drugs so which suppresses bone resorption as well as stimulate the bone formation, and it has potentially harm especially in terms of cardiovascular events and stroke, and they are contraindicated in the patients who are suffering from the cardiovascular disease. And they are the reserve drug for elderly patients with the severe osteoporosis and the patients who are not able to tolerate bisphosphonates. So continuing with the other drugs that takes part in the calcium homeostasis, the another drug is the selective estrogen receptor modulator, which you will be reading more detail in your reproductive classes. And this SERM, so which is the selective estrogen receptor modulator. So these are the group of drugs which have agonistic activity on some tissues, and these have antagonistic effect on some tissues, hence they are known as selective estrogen receptor modulator. And as for example, the drug here is the Rolexifene, and they are currently used for the treatment of postmenopausal osteoporosis. So, meaning that they have agonistic activity in some tissues, as for example, bone. So they cause bone formation, and they have antagonistic effect on some tissues, as for example, breast and the endometrial cells of the uterus, and hence they have antagonistic effect on the breast and endometrial carcinoma. They are used for the treatment of breast cancer and the uterine cancer. However, since they have agonistic activity on the bone, they causes the bone formation. So raloxifene is currently being used for the treatment of postmenopausal osteoporosis. So postmenopausal osteoporosis, which occurs in the menopausal state. So here there is deficiency of estrogen production, and estrogen, this has good effect on the bone. They causes bone formation, but in postmenopausal women, so since there is decrease in estrogen, so there is high chances of causing the osteoporosis. And this raloxifene has agonistic effect on the bone, so it increases the estrogen effect on the bone and causes the bone formation. So coming to calcium preparations, there are different calcium preparations, as for example, calcium carbonate, calcium citrate, gluconate, lactate, dibasic phosphate, and chloride. And they are used in different conditions like tetany. So tetany, so which occurs as a result of low blood calcium, which occurs as a result of hypocalcemia, and it results in the spasm of different parts of the different muscles of the body, including the hands and feet, so including the abdomen, spasm of larynx, etc. So they are this calcium preparation. So especially here, IV calcium gluconate is given in the treatment of the tetany, and calcium are also given as a dietary supplement, especially in the growing children, in the postmenopausal women, in the pregnant woman or the lactating woman. So they are used as dietary supplement as well, and in the treatment of osteoporosis as well. So for the treatment of osteoporosis, usually bisphosphonates or the hormonal replacement therapy is given, but the additional treatment with calcium as well as the vitamin D is given for the prevention as well as for the treatment of osteoporosis. And calcium carbonate is given as an antacid for the treatment of peptic ulcer or the gastritis. So this finishes the drugs that takes part in the calcium homeostasis. So hormones that takes part in the calcium homeostasis. So continuing with the same, we do have some MCQs. Respond to this. Patient was prescribed alendronate. She was advised to take large amount of water and remain in standing position for at least half an hour after taking drug. These instructions were given to reduce the risk of cholelithiasis, constipation, osteonecrosis, erosive esophagitis. So esophagitis is the major adverse effect that occurs with the use of bisphosphonates, especially when they are given orally, and hence these instructions are given. So the answer is D. So which of the following is the fastest calcium lowering agents? Calcitonin, calcitriol, etidronate, zoledronate. The fastest acting calcium lowering agents is calcitonin, and hence they are used to supplement bisphosphonates. So although zoledronate also reduces the blood calcium level, but calcitonin is more faster acting calcium lowering agents than that of the zoledronate, which is the bisphosphonates. So the answer is A. Prevention or treatment of osteoporosis in postmenopausal women may be achieved by all except estrogen and progesterone hormonal replacement therapy, calcium and vitamin D supplementation, bisphosphonates, multivitamins. So which of the following is not used for the treatment of osteoporosis in postmenopausal women? Any other answer? In postmenopausal women, osteoporosis is very common because due to the deprivation of the estrogen secretion by the ovaries, and as a result, estrogen has good effect on the bone. It causes the bone formation, inhibits the bone resorption process. So usually for the treatment of this postmenopausal osteoporosis, so hormonal replacement therapy is given, in which there is either alone the estrogen or there is combination of estrogen as well as the progesterone. So this is one of the mainstay in the treatment of the postmenopausal osteoporosis, hormonal replacement therapy. Similarly, bisphosphonates are another treatment, another drug of choice for the treatment of postmenopausal osteoporosis, apart from the hormonal replacement therapy. So along with hormonal replacement therapy and bisphosphonates, calcium and vitamin D supplementation is also given, but the multivitamins are not given. So the answer is it's D. So bisphosphonates acts by increasing osteoid formation, increasing mineralization of the osteoid, decreasing osteoclast-mediated resorption of the bone, decreasing parathermal secretion. Any other answer? So although mechanism of bisphosphonates has not known properly, so it has been thought that it decreases the osteoclastic mediated resorption of the bone. So the answer is C. So this finishes the chapter, drugs taking part in the calcium homeostasis. So any question? Any question? So if not, so we are moving towards the practical sessions, and BDS को लागि clinical problems as well as prescription र MBBS को लागि clinical problems र prescription छुट्टा छुट्टै नै छ, but कति चाहिने सेम नै छैन. So we'll be discussing the same. So पहिला last year सम्म चाहिने यो क्वेशन्सहरु चाहिने BDS र MBBS को चाहिने एउटै थियो, बट अहिले चाहिँ नि डिफ्रेन्ट गराइएको छ. So continuing with the clinical problem, so we'll be starting with the BDS. So यसमा पनि question number 1 or 2 चाहिँ नि MBBS को पनि similar छ. So we'll be discussing with the question number 1, clinical problems associated with the related to the endocrine system. So patient diagnosed to have SLE was put on prednisolone 100 mg per day, and मैले मेलमा पठाएको थिएँ यो क्वेशन्सहरु, and I asked you to do the questions, solve the problems, and I said we'll be discussing the same in today's class. So I hope you have gone through it. So a patient diagnosed to have SLE was put on prednisolone 100 mg per day. After 1 month, the patient noticed changes in his face. His stool started becoming tighter, and the urine shows positive Benedict test. So questions are: explain how the above side effects has occurred, at what time of the day should prednisolone be administered, give reasons, and what are the dangerous effects of stopping the drug abruptly. Sir, let's explain. So anyone want to voluntarily answer the question?
Yes, ma'am.
Okay, yes. Yes, Ozzy?
Yes, ma'am. Actually, prednisolone long-term use गरिरहेको छ. So there may be symptom of Cushing syndrome.
Yes, yes. भन्दै जाऊ.
Cushing syndrome को symptom चाहिँ हुन्छ किनभने पेशेन्टलाई हैन सोज अरु टाइट भइराछ अनि ड्यू टु पेडल एडिमा हुन्छ हैन सोडियम र वाटर रिटेन्सन भएर अनि बेनेडिक्ट टेस्ट पोजिटिभ भनेपछि त्यसको युरिनमा सुगर देखिराछ ग्लुकोज देखिराछ अनि हाइपरग्लाइसेमिक स्टेट भइराछ अनि त्यो सबै कुशिङ सिन्ड्रोम जसमा देखिन्छ हैन सो मोस्ट प्रोबेबल कुशिङ सिन्ड्रोम देखिन्छ अनि सेकेन्ड भनेको एट व्हाट टाइम अफ द डे भनेपछि मर्निङ मा बेस्ट सुटेबल हुन्छ किनभने त्यो हाम्रो बडीको नर्मल सिन्कार्डियन रिदम हार्मोनल रिलीज सिन्कार्डियन रिदमसँग म्याच गर्छ मर्निङ टाइम सो मर्निङ टाइममा एडमिनिस्टर गर्न चाहिँ ठीक हुन्छ डेन्जरस इफेक्ट अफ स्टपिङ एब्रप्टली स्टप गरे भने चाहिँ एड्रेनल इन्सफिसियन्सी हुन सक्छ हैन किनभने हामीले लङ टर्म सम्म एक्सटर्नली दिइराछौं भनेपछि त्यहाँ हाम्रो एड्रेनल ग्ल्यान्डको एट्रोफी हुन सक्छ हैन त्यसपछि एक्कासी एब्रप्टली हामीले छोड्यो भने प्रोडक्सन चाहिँ एकदमै थोरै हुन्छ हाम्रो एड्रेनल ग्ल्यान्डमा जसले गर्दा एड्रेनल इन्सफिसियन्सी हुन सक्छ
Okay, Ozzy, so thank you, Ozzy. So the answer is similar. So why the above side effects is occurred? So it is due to the Cushing syndrome, and Cushing syndrome occurs as a result of lipolytic activity, in which there is release of free fatty acid from the extremities of the body, whereas there is a central deposition of the free fatty acid leading to the moon face, similarly truncal obesity, buffalo hump हुन्छ and the shoes has started becoming tighter because of the edema, so sodium and water retention हुन्छ. So prednisolone has some mineralocorticoid activity as well, which leads to the sodium and water retention, leading to the edema, and this is the reason his shoes has started becoming tighter. And prednisolone or corticosteroids अर्को important adverse effect is also the hyperglycemia. So urine has showed the positive Benedict test. And at what time of day? It is in the morning. It is in order to mimic the circadian rhythm. So it is in order to mimic the endogenous production of the corticosteroid secretion. And when these corticosteroids are stopped abruptly, suddenly, so there can occur acute adrenal insufficiency, so which is emergency condition. And when you are giving this corticosteroid for a long period of time, so internally, so adrenal glands ले चाहिने आफै चाहिने यो endogenous production of adrenal hormones, so के हुन्छ त start becoming less or suddenly stop हुन्छ. So when these drugs are being given for long period of time, and you are suddenly stopping the drug. So if the exogenous चाहिँ जुन दिइराखेको थियो स्टप भयो, अर्को चाहिँ endogenous पनि के हुन्छ त स्टप हुन्छ. So this can lead to the acute adrenal insufficiency. So this is the dangerous effect on stopping the drug abruptly or suddenly. So coming to second clinical problem of diabetic hypertensive patient. So patient is both diabetic as well as the hypertensive. Attends the clinic for lipoma excision after taking the routine dose of lenti insulin and propranolol. So for diabetes, the patient is taking insulin, and for hypertension, the patient is taking propranolol. So he went for lipoma excision. As he was waiting for his turn for 3 hours, he developed excessive sweating and giddiness. On examination, his pulse rate was within the normal limits, whereas the blood pressure was increased. What could be the reason for sweating and hypertension? Explain why pulse rate remain normal. So what is your immediate line of treatment? And if excision under local anesthetic is decided, which of the following preparation would you prefer? It's plain lignocaine or lignocaine with adrenaline. So give reasons. So does anyone want to answer the question? हजुर भन. Good side effect. Mm. Mm. So which can be dangerous, you know. It's a new education platform को नाम चाहिए. Milan, oh? Okay, Milan. So thank you, Milan. So do you want to continue your answers? So your patient लाई चाहिए sweating र giddiness चाहिए किन develop भएको? Okay, so sweating र giddiness यसमा दुईटै चाहिँ नै हाइपोग्लाइसेमियाले नै गर्दा हो है. So thank you, Milan. So patient is diabetic as well as hypertensive. So patient is taking insulin as well as a propranolol for the same. And patient was undergoing the lipoma excision. So for which he waited outside the office for 3 hours. So यसले गर्दाखेरि के भइरहेको छ भने पेशेन्टले चाहिँ इन्सुलिन पनि लिइराखेको छ, अर्को चाहिँ नि पेशेन्टले 3 आवर्ससम्म केही पनि खाएको छैन. सो वेट गरिराखेको छ. द पेशेन्ट हेज अन्डरगन हाइपोग्लाइसेमिया. So you know the signs of hypoglycemia. There is increase in sympathetic discharge. So sympathetic discharge increase भएको मतलब there is increase in sweating, there is increase in palpitation, there is increase in anxiety. So this sweating as well as giddiness are the reactions to the sympathetic discharge as a result of the hypoglycemic episodes. And due to the decreased glucose entry to the brain, so यहाँ चाहिँ giddiness develop भइराखेको छ. And patient लाई चाहिँ नि pulse rate नाम्दा चाहिँ नि it was normal but blood pressure was increased. So pulse rate चाहिँ नि किन normal छ भन्दाखेरि patient is also taking propranolol. So propranolol acts on beta receptors. So pulse rate is increased due to the increase in heart rate. So normally, so increase in heart rate भएपछि, so there is increase in pulse rate, so it is as a result of sympathetic discharge. So patient since the patient is taken here propranolol, ले चाहिने beta 1 receptors block गर्छ, जसले गर्दा चाहिने pulse rate चाहिने यसमा चाहिने normal नै देखिराखेको छ. So since it is able to inhibit the beta mediated increase in heart rate, so here the pulse rate is normal. But blood pressures and sympathetic discharge, sympathetic overstimulation of sympathetic activity, there is increase in blood pressure, there is increase in pulse rate as well. But pulse rates are normal because it is inhibiting the beta 1 receptors, so mediate action. And whereas here the blood pressure is increased because although it inhibits beta receptors, but के हुन्छ त भन्दाखेरि चाहिँ there is increase in sympathetic activity, so propranolol beta receptors block गर्छ, but they are not able to block the alpha mediated hypertension. So beta receptors block गर्छ, but there is unopposed alpha action. So unopposed alpha action भनेको there is increase in peripheral vascular resistance, there is vasoconstriction, which will lead to the increase in blood pressure. So propranolol is able to block beta receptors but not able to block the alpha receptors. So it is due to unopposed alpha action. So blood pressure increase भएको छ, but pulse rate is within the normal limit. So what is your immediate line of treatment since the patient is undergoing the hypoglycemic episodes? And so obviously you know the treatment for hypoglycemia, so it is obviously the glucose, and the patient here is conscious, so conscious you can give the glucose in oral form, so give oral glucose. And third question एउटा MBS मा चाहिँ अहिले चाहिँ remove गरेको छ, but still in BDS. So if excision under local anesthetic is decided, which of the following preparation would you prefer? Lignocaine or lignocaine with adrenaline? Give reasons. This is one of the important question as well. So कुन चाहिँ prefer गरिन्छ होला? So patient is undergoing lipoma excision. So lipoma
lignocaine with adrenaline.
So why you are telling lignocaine with adrenaline?
Because adrenaline local vasoconstriction गराउँछ, so local effect of anesthetic मात्रै हुन्छ, अरु बेला चाहिँ systemic effect हुन सक्छ if हामीले adrenaline दिएन भने.
Can you repeat once again?
Because adrenaline causes vasoconstriction in that area, so there is only limited local action of that anesthetic. Otherwise it can go to the systemic, so it can cause systemic side effects also.
So your answer is lignocaine with adrenaline, or plain lignocaine need to be given to this patient? Yes, Alzay.
Like
your patient patient is undergoing lipoma excision, so for which we give obviously the lipoma भनेको चाहिने, so we give the local anesthetic for excision, so you want this patient so mixed with lignocaine to be given with mixed with adrenaline, or plain lignocaine for the lipoma excision?
systemic side effect चाहिँदैन भने adrenaline पनि एड गर्नु पर्छ.
When तिम्रो answer के हो? Systemic side effect हरु त्यो नभन न. What is your answer?
Lignocaine with adrenaline, I think.
So lignocaine with adrenaline, अरु कसैलाई answer दिनु मन छ? So it can be lignocaine with adrenaline or lignocaine. Do anyone want to add the answer? So I hope you remember the advantage of using or advantage of combining adrenaline with lignocaine. So lignocaine is local anesthetic and used for local procedures, as for example dental extraction or also incision and drainage गर्दाखेरि कुनै abscessहरु similarly and lipoma excision को बेला use गरिराखेको छ. So in most of the cases we use the lignocaine. So local anesthetic along with adrenaline. So I hope you remember the advantage as well. So adrenaline is a vasoconstrictor. So के गर्छ भन्दा यो कम्बिनेसनले चाहिँ नि when lignocaine or local anesthetic is given along with lignocaine is given along with adrenaline, since adrenaline is a vasoconstrictor. So vasoconstrictor भएर के हुन्छ भन्दाखेरि चाहिँ नि it flows the limit of drug through the particular blood vessel. So close limit भनेको चाहिँ नि it will now have the longer duration of action. Local anesthetic or the lignocaine will have the longer duration of action because adrenaline has caused the vessels constricted. So little amount of blood flows to that vasoconstricted area. So the duration of action of lignocaine or the local anesthetic will be more. And the another advantage is since less amount of drug flows through that vasoconstricted vessel. So systemic toxicity that is associated with local anesthetic is less. So एउटा चाहिँ नि duration of action of local anesthetic prolong गर्ने भयो. अर्को चाहिँ नि systemic toxicity that is associated with local anesthetic will be decreased, and it is due to the vasoconstrictor effect of the adrenaline. And here the patient is diabetic, the patient is hypertensive, and he is undergoing for the lipoma excision. So यस्तो patient, especially if the patient is hypertensive, we don't give this combination. So adrenaline along with lignocaine along with adrenaline is not given because patient is already hypertensive, and if we give this combination form of lignocaine along with adrenaline, so adrenaline ले के गर्छ भन्दाखेरि so it causes the vasoconstriction. So vasoconstriction भनेको it will further increase the blood pressure, and in hypertensive patient there is already increase in blood pressure. So adrenaline or combination of lignocaine with adrenaline दिँदाखेरि के हुन्छ त अझ vasoconstriction गर्छ. So there will be exaggeration of the increase in blood pressure. So in this case we only give the plain lignocaine. The hypertensive patient मा चाहिँ we give only plain lignocaine, not combination of lignocaine along with adrenaline. So continuing with the clinical problem.
I had a question. Suppose the patient is hypertensive, sympathetic.
Can you repeat once again?
Ma'am, can I type?
Banana. Let's go on.
I'll type the question.
Awesome. If the present patient चाहिँ नि hypertensive थिएन भने चाहिँ नि it's obviously lignocaine with adrenaline है. So because in most of the cases of local procedures when we are using lignocaine or local anesthetic, so यसमा चाहिँ नि usually adrenaline चाहिँ नि combine गरिन्छ है in most of the cases, but there are some exceptions like अहिले चाहिँ नि hypertension. Similarly, the patients who are suffering from the hyperthyroidism, especially thyrotoxicosis patientsहरुमा चाहिँ नि दिनु हुँदैन. So there are other exceptions as well. Local anestheticहरु चाहिँ नि usually locally नै दिइराखेको हुन्छ. It's not given systemically. Systemic circulation मा त जान्छ, but local चाहिँ नि can you repeat once again? Adrenaline त in arteries मा जान्दिनै मिल्दैन. It's not given in normal cases as well. In the arteries already there is constricted blood vessels, so त्यसले गर्दा adrenaline is contraindicated in arteries. So if you remember, so they are तिमीले पढेको पनि थियो. So in arteries, as for example, your tip of the toes or nose earlobes they are contraindicated. In the arteries they are not given. Okay. So एकछिन है, यहाँ एउटा के क्वेशन थियो. Patient was not. So usually if the patient is diabetic, So यसमा चाहिँ नि lignocaine along with adrenaline while doing the local procedures is usually not contraindicated, right? So diabetic patients मा चाहिँ नि lignocaine along with adrenaline चाहिँ नि दिनुहुँदछ. But patient here is hypertensive, so patient hypertensive को कारणले गर्दा चाहिँ नि यो combination चाहिँ नि this is not given, so plain lignocaine is given. So continuing with the clinical question, so Mrs. Gurung यो चाहिँ नि MABS मा छैन, so it's only in BDS, so but it's important as well. So Mrs. Gurung, a 30-year-old non-case of hypothyroidism, was well maintained on oral levothyroxine 100 microgram daily. She is free from symptoms of hypothyroidism. She became pregnant during the course of therapy. What is the rationale for choosing T4 in this case? How long is the treatment to be continued? Is it necessary to monitor the dose of T4? How is therapy with T4 initiated and maintained? Does the change in patient's condition, that is the pregnancy, does require any changes in the dosage schedule? So give reasons for your answer. What is the clinical prevalence of the differences between T3 and T4? So do anyone want to answer the question? So do anyone want to answer the question? Sophia? So I would like to answer this question by any one of the BDS students. Anyone? So this is the case of the hypothyroidism. Yes.
Yes, ma'am.
Okay, please go on.
The rationale for choosing T4 in this case is T4 is normally stable. It has a longer half-life. Also, it doesn't have a side effect such as cardiotoxicity. Only so here the T4 is chosen over T3. Also, T4 can be converted into T3 in the peripheral part. Thus, T4 is used here, and the treatment is how long is the treatment to be continuous? The treatment should be continuous by monitoring the level of TSH. If the TSH level is very low, that which is caused due to the negative feedback mechanism. So by monitoring the level of TSH, the treatment can be continued.
Okay, so answer to other questions.
Is it necessary to monitor the dose of T4? Yes, it is necessary to monitor the dose of T4 because its overdose can cause hyperthyroidism. How is therapy with T4 initiated and maintained? T4 is normally initiated by giving a single morning dose दिनुपर्छ अनि यसमा चाहिँ पेसेन्ट चाहिँ प्रेग्नेन्ट प्रेग्नेन्ट छ नि त प्रेग्नेन्ट भएपछि चाहिँ नर्मली हाई डोज इज रिक्वायर्ड लेभल अफ T4 or does the change in the patient condition of pregnancy require any change in the dosage schedule? Give reason for the answer. Yes, because the patient is pregnant, so higher dose of T4 is needed because during pregnant, both the child, both the fetus and mother need high level of iodine. What is the clinical relevance of the difference between T3 and T4?
T3 and T4 तिमीले भनि नै सक्यौ सन्तोष. Thank you, Santosh.
Thank you, ma'am.
यसमा चाहिने so rationale for choosing T4 in this case. So you know the advantage of using T4 over T3. So although the T3 is more potent than T4, so in most of the case we use T4, and you know the advantage. So you should be writing the same. So how long is the treatment to be continued? So usually your T3, T4 or the hormonal replacement therapy, or usually 3 months and then lab investigation.